Okay, so we might make a start. I'm Jo Silver. I'm the GP advisor at Western Health. So I'd like to welcome everybody along to our session this evening. We have with us tonight Steph from the PHN, who's helping with all the IT behind the scenes, because I would kill it if it was left to me. Our speaker tonight is Thomas Bicknell, who I will introduce fully later on, but welcome, Thomas. And we also have with us Dr. David Smallwood, who is the Deputy CMO at Western Health. So he's come along to see one of our sessions and answer any questions if anybody might have them about the amalgamation of Western and Djerriwarrh Health Service. So David is a respiratory physician by background and has previously worked at the Austin and has done lots of work with the units over there on communication with primary care and clinical handovers. So thanks, David, for coming along tonight. So our session tonight is on the virtual fracture clinic and the basic fracture management in the adult population. So next slide, thanks. I'd like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woi-wurrung people, the Boon Wurrung people and the Wathaurong people. We pay respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Just a little bit of housekeeping before we start. So everybody will be muted, and if you can ask your questions in the Q&A function only, please don't put it in the chat box because I'm simple and I can't cope with both. We're going to sort of try and ask the questions as we go through the session. So I'll pop in and interrupt Thomas as the questions arise. The session will be recorded, so if you don't want your name in the questions, then you can just ask those anonymously. So we also ask that if you have registered and you've got yourself down as Stan's iPhone or something, if you could just change it to the name that you registered for the event with, or if you can't do that, just put in the chat box for Steph so as she knows who you are and can make sure that she's got you down and you get your CPD credits. At the end of the session, we will put a link into the evaluation, and this will also be emailed to you tomorrow. So we'd ask that you complete the evaluation because it really helps us to plan future sessions. We'd like to know what worked and didn't work for you. Some people are telling us we're over Zoom, others love it because they can sit at home, have their dinner, deal with kids and have a little drink while they're getting an update. We will send you the PowerPoint presentation in about a week and also the link to the recorded session, and Steph will have your CPD points credited and will show on your CPD statement in about a month's time. And at the end of this session, I've just got a slide to give you an update on what's happening with the antenatal services at Bacchus Marsh and Sunshine amalgamating. Just before Thomas's presentation, just a reminder to everybody about Health Pathways Melbourne. This is a single website, many of you will have accessed it, with clinical and referral pathways and resources that you can use at the point of care. The pathways are written by local GP, clinical editors, with support from the hospital specialists and other subject matter experts. They have in them, there's lots of fracture pathways, so a whole suite of those. So you'll be able to have a look at those and get an update after Thomas's presentation as well. And the pathways are all laid out in the same way. So there's just the next slide, Steph. They're all laid out in an assessment section. So you can work out what you need to do with the patient. The next slide has got the next section on the pathways is management. So how you're going to manage those fractures or other problems that you may encounter. And then there's the referral information. So how to refer those patients into the various health services across Melbourne, whether that injury requires an urgent referral or whether it can be a non-acute injury that you can fax a referral in for it to be triaged in outpatients. So next couple of slides, Steph. So that's the acute information there. So easily laid out for you to quickly glance through and work through that while you've got the patient with you. And then the next slide is the non-acute information and the patients that you can, like I said, just fax in that referral. If you aren't already registered for Health Pathways Melbourne, then I'd encourage you to contact the PHN and get them to give you access, and you'll be able to work through a whole suite of different clinical issues. So it's really good. You know, I do lots of women's health and paediatric stuff, but fractures are a bit challenging for me. So it's a good way to just have a central spot where you can look for that information. Thanks, Steph. So I'd like to introduce our speaker this evening. So Thomas Bicknell is an advanced practice physiotherapist who's working in our emergency department as a primary contact practitioner and also in the virtual fracture clinic at Western Health. He's also been involved in the last 12 months in developing the Australian first non-weight bearing coordinator position as an advanced practice position that helps provide care for Western Health's long-staying non-weight bearing population. And we do have quite a lot of those patients in our health service. Thomas has worked across multiple public health services in Australia and in the UK, and has been now back at Western Health for about 8 years, Thomas, 7 or 8 years, and he's passionate about educating health professionals and students. So I'll hand over to Thomas now.
Thanks very much, Jo, much appreciated. I'm just going to bring up my screen. So, as Jo mentioned, I'll be talking to you today about the virtual fracture clinic and sort of basic fracture management through my experiences at Western Health in the emergency department and through the virtual fracture clinic. And I just encourage anyone to ask any questions as we're going along. There'll be a lot of case presentations of different conditions that we'll be looking at. So I'd encourage you to ask questions if it's relevant to those cases. And yeah, I'd be happy to have a chat about any of that. So what's the background of the virtual fracture clinic? So basically the roles originate in the UK in 2011 from the Glasgow Royal Infirmary, who redesigned their services for non-operative management of fractures and established the Glasgow fracture pathway. Scaling of this service has happened throughout the NHS, facilitated considerably by the Brighton and Sussex NHS Trust, which is a major trauma centre. Their virtual fracture service is a physio-led model that has won multiple awards, published significant amounts of research and has shared resources. If we look at the outcomes from the UK, they've demonstrated very good clinical outcomes, reduced demand on outpatient services and positive economic outcomes, as well as patient satisfaction. In terms of specific clinical research, all of the conditions there have been shown to be successfully managed in a virtual or shared pathway. And I think this is really important given our recent history with the pandemic over the last 2 to 3 years, that we're able to manage certain conditions successfully virtually rather than having our waiting rooms full of patients like they were in the past. So the question then is, how can this model of care relate to our Australian healthcare system? To answer that, Better Care Victoria partnered with the Royal Melbourne Hospital, Western Health and the local primary health network. And they implemented 2 different models of care over a pilot period in 2017. Royal Melbourne Hospital is a level 1 trauma hospital, and it trialled an orthopaedic consultant-led model of care where they have the advanced practice physiotherapists collating information for triage and then carrying out the management plan as determined by the orthopaedic consultant. At Western Health, we implemented a physiotherapy-led model of care. Both models were successful with similar outcomes at the end of the pilot and have been embedded into usual care. So today we'll be talking more about our Western Health model of care. So for those who are unaware or want a bit more information, obviously Western Health is 3 acute hospitals, and that's imminently changing. with approximately 1,100 beds and over 6,500 staff. There's very much a growing community of over 800,000 people in the area. And one of the great things that I love about working at Western is that it's one of the most culturally diverse communities in Victoria, with approximately 38% speaking a language other than English and over 100 different languages or dialects amongst those. So what does our fracture clinic look like in 2022? Well, why has it been going for the last 6 or 7 years? It's to access care for this growing population, and there's obviously significant demand for our once weekly fracture clinic that happens at Footscray Hospital on Tuesdays. You know, at the moment they can see anywhere between 200 to 300 patients on a normal day, and upwards of that at times. Therefore, patient experience is affected. Think about travelling to appointments, parking, lengthy waits times. And really, they're doing this and their management might not necessarily change. One other thing that we found within the fracture care when we looked at audits was that when they go in there, that management can often differ between clinicians. So we wanted to make sure we could standardise care for straightforward fractures and injuries. Not only was patient satisfaction affected, but also clinician experience. Clinics running overtime, staff were staying late and therefore being paid overtime if we're looking at the financial aspects of this. So if you look at our Western Health model of care, there's two ways that people come into our service. You've got anyone who comes to our emergency departments and requires management by the orthopaedic team will be referred to our virtual fracture clinic. They will have their notes ordered, and when they come from a GP, the referral will come in and they will have their referral triaged by an orthopaedic registrar. And as you can see, there are essentially 4 different ways that these referrals can go, regardless of whether they come from our emergency department or from local GPs. They can either go to fracture clinic plus or minus additional imaging. They can have a virtual fracture consultation. They might go to the orthopaedic consultant clinic, which is where our elective, so non-trauma patients will go. And a very small percentage of our patients will then go to other specialties like plastics or neurosurgery, or they may elect to go privately. If we look at through virtual fracture clinic how we manage our patients, then they'll have their initial appointment with us, and then they'll either have a review or be advised to see their GP for any further follow-up, depending on the condition that we're managing. So if we look at the Western Health model of care a little bit more, we're a physiotherapy-led model. That means that the physiotherapist is the one that drives not all of the decisions, but all of the processes that occur. We identify suitable patients for virtual care and make management decisions regarding their care. And then the orthopaedic consultants will make decisions on who require a face-to-face fracture clinic review and the timeliness of the appointment, as well as identifying patients who may need further imaging prior to coming to that clinic. So if we think about someone who's got, for example, a suspected scaphoid fracture, they may want a CT between the initial presentation and when they're going to go to fracture clinic in a week's time. The highest risk for virtual fracture clinics is in triage. So this is run by an experienced grade 3 advanced practice physiotherapist like myself, who has been credentialed in radiology and fracture management, as well as being credentialed in the emergency department. So our credentialing process is very thorough. And as you can see, there's been significant amount of we have significant amount of referrals coming to us, about 72 per week just from our emergency departments alone. That's a growth of about 1,500 over the last 4 or 5 years, those referrals. So we're about 2,200 5 or 6 years ago, and that's gone up to over 3,500. And if you think about that, it's a considerable amount of time. It takes 5 to 10 minutes to triage each referral. The chart's actually a little bit out of date. VFRAC, we're seeing approximately 35% of patients now with fracture clinics still sitting up around the 60% mark. So the physiotherapists, this is just a little bit about how we work, but with COVID, we've been working at home as well as in the office. We have dedicated phones for the virtual fracture clinic. So encourage patients, family members, and local GPs to contact us with any questions. And we also have a dedicated email account. One of the most important things about the email account is that we're able to send on care plans. We have standardized care plans for our most common presentations, in which it gives written information for our patients, and with safe netting advice and when to progress and when to see the GP and all that type of information that's going to be important for their ongoing care. So just in terms of the outcomes, this is from our initial pilot period, but as you can see, it's really important that it was a safe service that we were implementing. And we can see that the ED representation rate was only about 2.7%, and that was not due to adverse events during the trial period, but things like poorly controlled pain, so they need further analgesia, misfitting plasters, so nothing due to the care of the actual virtual fracture clinic, which was fantastic. You can see there's a lot of different information that we had gathered. And I guess the most important thing is that it was safe, and patients had a great experience. So they had an average score of about 8.6 out of 10, which is fantastic. Here are a few things that our patients had to say. I'll give you a minute to read some of those things. And I think one thing that resonates here, people appreciate it because they don't need to come into hospital. They don't need to wait 2 to 3 hours to have a 5 or 10-minute appointment with a doctor. They don't need to worry about parking. They don't need to now worry about getting ill because they're sitting next to someone who may be ill. So there's a lot of positives, and patients are really appreciative. And I can see that now as well in the emergency department. People love that they don't have to come in and wait. So it's been really good so far in the last 6 or 7 years. So rather than talk about a lot of the boring stuff, I thought let's concentrate on a lot of case studies, things that are applicable to our day-to-day work.
Sorry, Thomas, before we start, can I just ask a couple of questions? Can I just ask how you contact the GPs? How do you manage that?
Yeah, so there should be a discharge summary that goes to GPs automatically through our services. So anyone that goes through our service has notes written, and our understanding is that there should be discharge summaries sent out to the GPs. We wouldn't routinely contact the GP unless we thought there was something that needed to be followed up or there was a query from them.
Great, thank you. And if patients needed analgesia and they weren't going to go into ED, are you just directing them back to the GP for that? Is that how that works? Yeah,
so we don't have prescribing rights. And I think the important thing with that is obviously when prescribing analgesia, an associated clinical assessment comes along with that. So sometimes we may ask people to represent to the emergency department. Usually it's not for pain management. That would be more to the GP.
Great, thank you.
So I've organised these case studies into lower limb and upper limb, and I wanted to have a look at the most common things that we see within our virtual fracture clinic, as well as things that come into our emergency department quite a bit and I think might be relevant to those who are listening today. So thinking about the first case study, think of a 46-year-old male who stubbed his 5th toe against a coffee table. So automatically, with my ED hat on, we think stubbed toe, is it broken, is it not broken? But also thinking about, are there any wounds? Is it an open fracture? And what's the status of the nail bed? So routinely we get x-rays for this type of injury. And as you can see there, that there is a comminuted, mildly displaced fracture at the proximal phalanx of the 5th toe, and very minimally displaced. this is very common. We see this all the time. Often people will forego the GP and come straight to the emergency. And how do we manage that? So with our care plans, we buddy strap. So we buddy strap the fifth and the fourth toes together, always putting some padding in the middle just to make sure that we're not encouraging any sort of fungal infections, and making sure there's no sort of too much skin on skin contact. And you can advise the patients to wear a stiff soled shoe. So they don't need to wear a stiff soled shoe, but we often find that a stiff soled shoe stops movement through the fracture side or movement through the toes, so they're not getting as much pressure there. Usually we say for about 3 to 4 weeks, and then to wean the buddy strapping, and to gradually return to some normal activities, with the idea of avoiding really high contact or high impact activities for about 6 weeks. So running, jumping, going up and down ladders all day long. And then we will often manage this in our virtual fracture clinic and then follow up with a GP. Routinely, we wouldn't need to re-X-ray unless clinically indicated, or we thought there was sort of any movement of the fracture or displacement that warranted further advice. So going on to our next one. So that's the same for all of our smaller toes, or what we call our lesser phalanx fractures. So anything other than the great toe. So in this second one, this is a 65-year-old male who accidentally drops 50 kilograms of steel onto the toes, the great and the second toe, with immediate pain. With this, obviously, straight away, we need to think there's 50 kilograms of steel, so a significant amount of force, and therefore we've got a crush fracture, or a crush type injury, I should say. And the clinical examination is really important in this one. Greater risk of being an open fracture. There is a subunguinal hematoma of the right great toe, but the important part, it is closed. And as I mentioned in the last slide, we need to make sure we're looking at the nail bed and the integrity of the nail bed. So if we look at the X-ray, we can see there that there's a comminuted, sort of mildly displaced fracture through the distal phalanx of the right great toe. This in isolation is managed routinely. This would be a Darko shoe or stiff-soled shoe for 3 to 4 weeks. No further imaging and follow-up with the GP. But when you've got 50 kilograms going through the toe, there's a good chance that there might be other associated injuries with that. So this, interesting, this is an actual case, but this one we sent on to fracture clinic due to the nature of the injury and the nail bed involvement. And it actually turned out the nail bed was infected and they were admitted for surgical debridement. So interestingly, we don't see many toes that go on to require operations. And normally it is because of infection, nail bed injuries, or open fractures. Otherwise, they're usually managed conservatively. And in my experience, most great toe fractures are managed weight bearers tolerated in the Darko shoe, but there are circumstances, particularly when it's the proximal phalanx, it's intra-articular, and it might be really, really comminuted, that they may non-weight bear them for the period of time, but normally it would be weight bearers tolerated Darko shoe, follow up with the GP. So here you can see just our standard management for great toe fractures. 3 to 4 weeks in the Darko shoe, and then from the 4 to 6 weeks, trying to wean that and then getting back to activity during the 6 to 12 weeks. When we send these care plans out, it's not just this is not just what they get, it's about 3 or 4 pages. And hopefully, if you've ever seen some of these patients in your clinic, then you would know what they look like, and they've brought them in with them. So going on to the next one, 57-year-old male with right ankle pain post-fall from a step ladder while changing a light bulb. So this seems to be all too common these days. And they often feel a crack and then sudden onset of pain and difficulty or inability to weight bear. With this one, the clinical examination of right foot swelling over the lateral metatarsal region with a tender fifth metatarsal, and minimal right foot pronation supination. So when we think about pronation supination, it's sort of that bringing in of the sole and going out, inversion, eversion movements of the foot. So automatically, if we look at this X-ray, there's a lot to look at in the foot as always, but you can see there that there's a undisplaced base of fifth metatarsal fracture. Nothing else there. Not trying to trick you. And one thing that's really important to understand is that there's different classifications for the base of fifth metatarsal fracture. We have zone 1, 2, and 3 fractures. Zone 1 is typically like an avulsion type fracture of the bone. A zone 2 fracture is where the fifth metatarsal articulates with the fourth metatarsal. And zone 3 is a proximal shaft. Now these are often associated, can be stress type fractures. So if we think about, I guess just an example that comes to mind is, a young cricket player came into the emergency department the other day, and he was just running, warming up for cricket, and he just felt this all of a sudden sharp pain around that part of his foot. And he obviously had stress responses in the bone, and that jogging was the thing that caused the fracture. So if we go back to our case, then we can look there that's a fairly clear zone 1 fracture with slowly getting on the border of a zone 2. The great thing is that it's not going to change our management. This is one of the most common things we see. We see these all day, every day. And how we manage these, this is weight bearers tolerating the CAM boot for 6 weeks. You can provide crutches, you can provide analgesia. We routinely do not repeat imaging at the 6-week mark unless it's significantly comminuted or displaced. And in that case, we'd often discuss it with the orthopedic consultant to see if they would like further imaging. Important to know that they don't need crutches and that they come out of the boot regularly. Obviously, for weight-bearing activity, they wear it, but for sleeping, showering, resting, watching TV, they can come out of the boot. Important, 1, for ankle range of motion, and 2, for DVT prophylaxis. We don't want any unwanted blood clots in this population.
Sorry, Thomas, and are you providing them with printouts of exercises and things to be doing?
Yeah, great question. So at the end of the care plans, there'll be maybe a series of 1 to 2 exercises. So they might start, this is what you do when you're in the boot. So it will just be like ankle dorsiflexion and plantar flexion. We don't want them really going into inversion or eversion because we don't want to put too much pressure through the fracture site. And then it also gives them exercises for the 6-week mark. So when they're out of the boot, it might give them some heel raises and squats and single leg stance and things like that to do. One thing I haven't mentioned though, which thank you for prompting me, is that we will refer these patients on to physiotherapy within Western Health if required. And we'll offer them different options with that, but that's something we will routinely do if indicated.
Great, thanks, Thomas.
So the next case study looks at a 21-year-old male, so with another inversion injury. So this one's missed the bottom step, and this was 1 week prior to the GP attendance. So they've come in and after a week they've been struggling, so they thought they'd go and see their GP, and this is a referral that we had come through. So on examination, they can walk unaided, so their pain must be relatively well controlled. They got no knee tenderness and full range of motion. They got a tender lateral malleolus and no medial malleolus or foot tenderness, and they're neurovascularly intact. So here you can see that there's a very minimally displaced Weber fracture. Everything else with the ankle looks okay. No obvious medial malleolus or sort of syndesmosis widening, which is always important to check with this population. And the care plan for Weber is actually almost the exact same as our base of fifth metatarsal. As we say, a CAM boot for 6 weeks, weight bearers tolerated, out of the boot for sort of sleeping, showering, and non-weight bearing activity. And then we will follow them up at 6 weeks, as we will with the base of fifth metatarsal. The reason we put them, and a lot of people ask, well, why can I put all my weight through my foot? I've got a broken bone, it's going to move. the rigid sole of the cam boot actually makes sure that we're not putting sort of any untoward force through the bone, and that it's quite stable in there. There's a lot of research in these populations that show that it's safe to weight bear, and the great thing is that they can come out and make sure that they're still moving their ankle, because the last thing we want is a stiff ankle at the end of all of this. Again, we wouldn't routinely repeat imaging on a Weber A fracture unless clinically indicated. Often at the 6-week mark, when we say come out of the boot, the fracture line will very much be present. Hopefully there's callus formation, but even when they do go to the orthopedic clinic, often they'll go purely on clinical exam as opposed to radiological findings. So we're sort of working our way through the ankle now. The ankle seems to make up a lot of our injuries. So now we've got a 42-year-old female with a left ankle injury. So rolled their ankle at work. Clinical examination, very similar to the previous gentleman. Tended directly over the lateral malleolus with no other foot or ankle tenderness. As you can see with this one, I'll let you have a little look before I start rambling on. But as you could probably see here, there's a bony fragment at the tip of the lateral malleolus or the distal fibula. This is very typical of an avulsion type fracture, and avulsion fractures can vary in sort of shape and size depending on where they've come from. And we know with avulsion fractures, it's often it's from soft tissue pulling a small fragment of bone away from the donor site. So with the lateral malleolus avulsion fractures, as with all of our avulsion fractures within the foot or the ankle, the management is cam boot, weight bear is tolerated for 2 to 3 weeks and no more. Essentially how we treat these and how we describe these to our patients is that this is a really bad ankle sprain. And it is. There'll be associated soft tissue injury, and often the soft tissue is the biggest limiting factor with this population rather than the actual bony injury. The bony injuries generally do really well, but if there's significant soft tissue injury associated with that avulsion fragment, those tend to be the individuals that don't do as well. But we say 2 to 3 weeks, wean the boot from 3 weeks at the latest, and then slowly get back into regular activity. And we encourage this type of population to call us if they're struggling at the 3 or 4 week mark, so that we can organise outpatient physiotherapy for them. The other thing here is that this condition, we probably have a bit more leniency in terms of if we've got an 85-year-old gentleman who comes in with an avulsion fracture, who walks with a frame. If we put a cam boot on them and it's going to make them more unsteady and a greater risk of falls, we'll leave the cam boot off for this population. Anyone who's played netball, basketball, football, any high risk sport for ankle injuries, there's probably a large proportion of people who've had avulsion fractures without knowing. And so I think it's really important that that this is where clinical reasoning is really important, that if it's not appropriate for someone to be in a cam boot, then this is the type of injury that we can certainly say, okay, that's all right. We just need to be really careful for the next 3 to 4 weeks. We would not routinely follow this patient cohort up, and this is another one we'd encourage to see the GP for further input if required. All right, so now we'll get into the more juicy ankle injuries. And these are the type of injuries that we would encourage local medical practitioners to send to the emergency department for more definitive management earlier on. So think about a 58-year-old female with right ankle pain and inability to weight bear post rolling the ankle while stepping down a step. Again, it's a tender and swollen right lateral malleolus with mild medial tenderness, and that's really important. Medial tenderness in higher grade injuries is something that orthopedic surgeons will often look at to see if there's an indication for surgery or not. So it's really important we do a thorough examination to make sure that we're getting the most relevant information. So as you can see, as you can see from this imaging, we've got a Weber B fracture of the distal fibula. No obvious syndesmosis widening. So when we talk about syndesmosis widening, not sure if you can see my mouse or not, but we look at the joint space here between the tibia and the talus, and often you'll see widening on the mortise view. This joint space will not be equal, and that would be an indication for operative management, generally speaking. So this, as I mentioned, is one that we would encourage clinicians to send to the emergency department. We would normally in emergency put a back slab and U-slab, make them non-weight bearing, obviously analgesia, and then a repeat x-ray after the back slab and U-slab. These would almost always go to our fracture clinic. And in this situation, now I just need to remind myself here, but a 58-year-old that would almost always be non-weight bearing. However, the management has actually changed more recently, and management really is dependent on the stability of the fracture. Our guidelines within the emergency department say back slab, U-slab to start with, and then generally non-weight bearing for 6 weeks, and they may require an ORIF or diastasis screw or a wire to help with the syndesmosis if there is instability there. However, now there's a trend towards early weight bearing in stable fractures. So stable, undisplaced fractures, they're now tending to weight bear much earlier on. There's evidence coming out to suggest that it's safe to do so. And in the inpatient role that I've worked in the non-weight bearing coordinator, it's actually helped reduce length of stay significantly in some of our patients. Not the decision of the physiotherapist or the GP, in my opinion. This is something that should be coming from the orthopedic consultant or registrars who have a much greater knowledge of this than I do. So then on to our very last, and we've got a 22-year-old female with left foot pain. I believe that should be ankle pain. Doing a backflip on a bike and jumped off before landing and landed with most of their weight through the lower limb. Again, tender fibula proximal to the lateral malleolus. So not quite ankle, but more leg pain. Medial malleolus non-tender. Neurovascularly intact, reduced ankle ROM, and C-spine non-tender and full range of motion. Obviously, when we have any high energy trauma, it's important that we're completing full assessment of spine as well as other extremities to make sure that we don't miss any injuries. So as you can see here, we've got a Weber C type fracture. This is above the level of the syndesmosis. Whereas the Weber B is at the level of the syndesmosis. And you can see here that I haven't looked at this but official report, but I would say this would be widening of the slight widening of the syndesmosis at the mortise view. You can see on the lateral that here it looks like very sort of small area covered, but it actually extends quite high up into the shaft of the fibula. We know with Weber Cs, they almost always require operative management, particularly in a 22-year-old. So again, this is one straight to ED with a back slab, U-slab, and repeat X-ray. Non-weight bearing, analgesia, and she was advised that she would need an operation with 2 weeks from the emergency clinician. We would triage that. We know straight away that they need to go to fracture clinic, and often it would just be around the timing of fracture clinic. Unfortunately, we didn't find out the outcome for this patient because they returned to Italy, where they were from. But I would imagine that operation within 2 weeks would have been the most appropriate management here, given age and requirements. All right, so last one's not necessarily particularly a fracture, but a soft tissue injury of sorts. So a 28-year-old male presents with severe left ankle pain, went to sprint whilst playing football and heard a loud pop. So straight away we're thinking it's either a calf or an Achilles or a bit of both. I always say I'm a bit older than 28 now. I wish I was still 28, but being this age before that, we know that sort of 30 to 40-year-old males are very inclined to get Achilles and calf injuries. So with the clinical examination, a palpable gap in the left Achilles tendon, a positive Thompson's test, and extremely tender, which all sounds like an Achilles rupture. Now, interestingly, with this X-ray, there was actually a subtle lucency over the posterior process of the talus that may reflect an undisplaced fracture. Now, very uncommon to get a talus fracture with a suspected TA rupture. Often, if you see any type of bony injury, it would be through the calcaneum where the Achilles attaches. I think that was inconsequential. And then also on the mortise view, there was slight widening of the distal syndesmosis, which I can see, but again, very uncommon, particularly with no, I guess, trauma to the ankle per se. In regards to Achilles tendon ruptures, again, there's been a huge change over the last, I guess, 10 to 15 years about how we manage these. And the majority of our Achilles tendon ruptures are managed non-operatively. In the emergency department, we would put them into a cam boot with heel wedges. So 3 heel wedges that go about 1.5 to 2 centimetre rise to put them into plantar flexion. We would often organise an outpatient ultrasound. Now, the outpatient ultrasound will depend on the location of the rupture as well. Personally, I'm less inclined to do it for mid-belly ruptures because they're a lot easier to diagnose, as opposed to, say, a rupture around the musculotendinous junction. However, that's something that is part of routine care generally. This patient was followed up through VFRAC. Again, we sent him straight to fracture clinic. Interestingly, the management changed a little bit, and that would depend on the consultant who was in clinic at the time, but they put him into an Aquinas slab. And what an Aquinas slab is basically it's a back slab on the front of the leg with the foot down in a plantar flex position to, I guess, if we think about rupturing the Achilles, put them into a plantar flex position to take tension off the calf and the TA. They were made non-weight bearing for a week, and then they were changed into the cam boot with heel wedges. They go through these accelerated protocols. Some people will go with an operation. However, we know that the outcomes from operations, the big thing with surgical management, the only real benefit of having an operation is that you get greater push-off strength at about 1 year post-op. Obviously, there's greater risk of things like infection and failed surgical management. So a lot of our patients are now going through these accelerated programs, and this is just an example of an accelerated program that would often go through. There's a Willits protocol and a few others out there. If you Google them, there's many out there. So other common yes.
Sorry, Thomas, I've got another question.
Yep.
Do you have a time frame for how long they need to be in the heel wedge boot before they require surgery?
Yeah, that's a good question. I believe usually so if you're going through the whole protocol, you'd be in there for about 6 weeks, 6 to 8 weeks, depending, and then we'd wait for the clearance from the orthopods to get out of it. If they're going for operative management, they'd normally do it within a 2-week time frame. Normally that's sort of the window, but it really depends on the injury. But yeah, that's just from my experience.
There's another question. Do they need to be in the boot? Hang on, I'm just trying to read it. I mean, do you need it in the boot in a matter of 24 hours? I think, do they need to wear those wedges all the time?
Yeah, you should be, because really what you're trying to do is maintain that position. And I guess it's, you know, the options are you go into the boot 24 hours or you go into a plaster 24 hours. And this is probably the least restrictive, because we can actually walk on the plaster, not on the plaster, sorry, on the boot. So functionally it gives them better outcomes earlier. But yeah, they do need to stay in it 24/7.
And not take it off for showering?
It depends on, again, which orthopedic surgeon you ask and which consultant you ask, but it would depend again on the patient and their ability to remain in plantar flexion if you're going to take it off for the shower. Because what you don't want to do is, I guess, again, thinking about if you've got it in that position, if you've got your scar tissue healing up and then you start going into dorsiflexion too early, you potentially create poorer healing and poorer outcomes.
Mhm. All right, thank you.
So other common lower limb presentations, patella fractures, patella dislocations, lots of soft tissue injuries of the ankle and the knee. And those are the sort of things we'd manage through the virtual fracture clinic, as well as Liz Frank injuries and tibial plateau fractures, which are managed through fracture clinic and would be the other types of injuries that we'd encourage people to go to the emergency department for. So just a quick case study for the upper limb now. I probably have neglected the upper limb a little bit.
Sorry, Thomas, I've got one more.
Yep.
Before we go into the upper limb, how do GPs refer into the ED triage for the virtual fracture, and how do we go about organising cam boots?
Yeah, so it's a really good question. So you, as a GP, you can't refer directly to VFRAC, and that's probably, so that needs to go through that pathway, and then in the past, the orthopaedic registrar would then put them into VFRAC. And there was often a little bit of a delay just because of all the steps that would go through. That's changed due to, like everywhere, staffing issues. So often the GP referrals are going straight to the fracture clinic, but as our staffing improves, hopefully that changes and we can start to see some of those GP referrals again. And in terms of cam boots, yeah, it's tricky. Not having worked in the community much myself, you know, some GP clinics will stock them, others you can go to Opal. So any, like the orthotics specialist, you can buy cam boots at some pharmacies. The most important thing, and this is me being a bit anal, I guess you could say, sizing super important. Making sure that they get the right size for safety, but also for comfort and pressure areas. The worst thing you can see as a physio is someone walking in with the moon boot where their toes are off the edge, or they've got an extra 3 inches at the front because they couldn't find the right one. You know, in worst case scenarios, if it's about safety and you can't source it in the community, then I guess the emergency would be the place to come in, and that's where our physio practitioners work really well.
Yeah, I think Opal, you can make an appointment and get an assessment reasonably quickly, having had to do one myself. And yeah, I think the local physios will get them in sort of 24 hours. So it's sort of contacting your favourite person and hoping for the best. But they're about, you know, $60 to $100, which becomes an issue for some of our patients.
Yeah, and don't tell your patients, but that's one of the only things we charge for in the emergency, and it's about $40. So it's good quality, good price. So doesn't mean send all your patients to us, but yeah, it's sort of a one-stop shop sometimes, because patients know hopefully they're going to get the right care. Yeah.
So for the GPs, if you're doing a referral, just fax that referral in, highlighting, putting the information, you know, where the x-ray was and who the provider was, because they'll be able to get online and have a look at the films as well. So as much information in that referral of, you know, the method of injury, and then they can help get the triage done. Thanks.
So whiz through the upper limb, sorry, it always seems to be the one that misses out, but 22-year-old male who's come in with right elbow pain, playing volleyball, jumped, lost balance and fell onto the right arm. So objectively, there's swelling over the olecranon, reduced movements and pain on supination, pronation. So one of our other most common injuries, and very hard to see on these x-rays, but is radial head fractures. And I guess the thing to look out for here is that with our radial head fractures, we're sort of looking for 3 or 4 things here. And I'll go back up. Now that you can see the fracture line in this bottom one, it's quite easy to see. It's very subtle, but you can see it through there. And you can see that sort of this doesn't look quite right on the radial head, but we're looking for the anterior humeral line. So with all elbow x-rays, so the anterior humeral line, when the elbow is in 90 degrees flexion, should run through the middle third of the capitellum. We're looking for the anterior sail sign and the posterior sail sign. Now this is elevation of the fat pads within the olecranon fossa and the coronoid fossa. And then we're looking for the radiocapitellar line. So does the middle of the radius run through the capitellum? This is what we consider a Mason 1 fracture, a radial head fracture. And the reason that the radial head is a common injury is because when people fall down, if they don't break their wrist or something else, or if they're going to break something, this is because the radial head will butt into the capitellum, and it's not as strong as the capitellum. So with our management, we see, again, we see a lot of this type of injury. The sling is there for comfort. You do not need to immobilize this type of injury. We actually encourage you to mobilize as much as possible, particularly extension, because we know that loss of extension is probably the main thing. Flexion will often come back very quickly. Extension is the hard thing. After 2 weeks, we encourage people not to use the sling at all. And we want to make sure they're doing the exercises. And part of the big thing we talk about on the phone is the exercises. And no real lifting or loading for 6 weeks. So for a fairly small fracture, it's one that can affect people quite a bit. We would routinely follow this type of injury up with a call just to see how they're going. And we encourage them to call us within 2 or 3 weeks if they're struggling with their movement. One thing always to check with a radial head fracture is make sure they don't have a supination block. And we talk about a mechanical block as opposed to a pain block. So if you can get them passively around, that's great. But if they've got a mechanical block through passive range, that's an indication for sort of orthopedic opinion early. The other common thing we see in the upper limb is AC joint injuries. Football, any sports really where there's contact or people falling to the ground, and I guess the important thing with AC joint injuries is that there's the Rockwood classification of AC joint injuries, and what I guess is important is grade 1s and 2s. So basically with no movement or very little movement of the clavicle in relation to the acromion, are managed conservatively in a sling and then getting back to normal activity. Grade 3 is a bit of a murky area where surgery may be indicated depending on the needs of the patient. And then grade 4, 5, and 6 would almost always require an operation. A grade 4, you've got posterior displacement of the clavicle. Grade 5, you've got significant superior displacement. And grade 6 is inferior displacement, which is very rare. The only time I've seen it is when someone was attacked from behind and had a fist straight into their clavicle and it pushed it down. So with our grade 1s and 2s, sling as needed, gradual return to activity, try to avoid any sort of painful activities, arm across the body or too much overhead. And after 3 to 6 weeks, really starting to ramp things up. By the time that we're getting to 6 weeks, that we're slowly getting back into normal activity. Other VFRAC upper limb pathways that we have are sort of undisplaced clavicle fractures, shoulder dislocations, triquetral fractures, so triquetral avulsion fractures, which we get now and then, and soft tissue injuries. The one thing with soft tissue injuries are TFCC injuries. So over the ulnar border of the wrist, they can often be managed, be seen in the fracture clinic because they can be, I guess, on the worse end of the soft tissue injuries. So I guess just other things to consider, and I guess thinking about what the best thing for the patient is and the best thing for their time and for the hospitals and all those types of things is when should you send the patient to the emergency department? So having a good understanding of when urgent care is required is really important. There are hundreds and hundreds of different musculoskeletal injuries that we manage, and you know, it's hard to know exactly which ones, but I guess if any doubt, there are, I guess, resources we can use to help us make those decisions. Knowing when surgery is indicated is really good as well, because it sets a good platform for the patient. A lot of people we see will say, oh, I spoke to my GP, I spoke to my physio, I spoke to my mate next door and they said I need an operation. So knowing when surgery is indicated is really important, because it starts to create that expectation and gives patients sort of that reassurance around what their management may be. And one thing at Western, and this will be different at every hospital, but how do you know if you should refer to fracture clinic or plastics clinic? And all I'll say is that if you've got a fracture in any of the periphery, so the legs or the arms, except the distal carpal row and hand fractures, they all go to fracture clinic. So anything basically from about here up is plastics at Western Health. Anything from there down and into the legs is orthopedics. And the other thing as well is how are common soft tissue injuries treated? ACL ruptures, you know, everyone comes into emergency with an ACL rupture and they think they have to have an operation. We know now the big fad, especially in the physio world, because we spruik conservative management, is conservative management. We know there's great outcomes with conservative management. You know, how do we manage calf strains? Well, it's almost similar to an Achilles rupture in that we can provide them with 3 heel wedges in a normal shoe without the camber and slowly reduce those as the calf sort of gets better and they can start strengthening exercises. And things like rotator cuff pathology is very, very common within the population. However, you know, there's a certain population that surgery would be indicated, and there's certain population that wouldn't be indicated for. So I guess the more you know, the better, so that we can educate patients and make sure they go on the right pathways. So just some available resources. There is a internet site for the Western Health Virtual Fracture Clinic, has contact numbers. For any children's fractures, the RCH fracture guidelines are amazing. I look at those all the time when managing kids within the emergency department. Obviously, we spoke about the health pathways, and in real urgent cases, there's the orthopedic registrar on call at Western Health. So you go through the switch, and you know, if you're calling up about an ankle sprain, they're probably not going to be too impressed. But for anything urgent that you know is not for the emergency department, they may be able to give you some advice about the best ways. The other thing as well is that these are the virtual fracture care or virtual fracture clinic contact details, and any of our clinicians would be happy to have a chat. We're obviously very busy, so don't call us about every patient that comes through the door, but we'd be very happy to chat about anything at any time. So that's me. I'd encourage anyone to ask any questions if you have any. Thanks. I hope that was useful. I hope that got you thinking about a few things, and yeah, hopefully you don't need to send too many patients to us.
Thanks, Thomas. That's been fantastic. A really good overview. There's one more question here. It's a doctor who's asking, I'm dealing with a patient who had a complete patellar dislocation and occult fracture. She's in a splint brace for 6 to 12 weeks. What's your recommendations on rehab protocol during the first 3 weeks?
Yeah, so if it was just for a patellar dislocation without a fracture, that's relatively straightforward. But I guess with the fracture, it really depends on the location of the fracture. Is it intra-articular? So does it sit underneath the patella and between the patella and the femur? Is it on top? That's the type of thing that we'd routinely send for an orthopedic opinion, not necessarily for surgery, but to guide that management, because adding a fracture on top of a dislocation becomes a bit more hairy.
Okay, all right. And so then the orthopedic opinion would then guide the sort of rehab protocol for that person.
Yeah, so in terms of when they can start range of motion, often we start sort of inner range quads exercises really early, and we get them for muscle activation. But again, a fracture just adds a little bit of, and not knowing where that fracture lies makes it a bit more challenging to give further advice about.
Okay, great. Thank you very much. Well, that has been a wonderful presentation, and hopefully people are feeling a bit more confident about managing some of the fractures, and have got some idea about the services available and how to refer in. So like Thomas said, refer in through the referrals for triaging. And if it's anything that you're concerned about, then send the patient into ED. If you can't get the orthopedic reg, because sometimes they're in theatre and they get a bit grumpy when they come out of theatre and they've got 10 phone calls from us, then the ED consultants are often available and able to take the calls. And you may then also find one of the advanced care physios in ED as well. So lots of people are able to help, because I know lots of our patients are reluctant to be coming into hospital, and then some of them bounce in with what we would think is pretty minor things that the GPs can manage. So it is quite varied. So wonderful. All right. Steph, are you able to just pop up that last slide? And I think, Steph, you're going to share in the chat function, which I haven't checked, the evaluation link as well. Yeah.
Yes, has that come through for you,
Yep.
Jo? Great. And yes, the chat, the evaluation
yes.
survey.
Yep, that's fantastic.
Oh, perfect. Is in the chat.
Mm.
Thank you.
Yep, great. Thank you very much. All right. So, like I said at the beginning, Djerriwarrh Health and Western Health have amalgamated. So there is a whole team working on that transition piece, and it's, as you can imagine, it's a huge piece of work trying to align everything. So just to give you a bit of an update on what's happening in the antenatal space, because that's the one of the big changes that we're having. So as you know, Sunshine is a almost tertiary service, and Bacchus Marsh is more for low risk patients. So at Sunshine, we have been receiving referrals for patients who come from far and wide. So patients who are in Epping or Broadmeadows or Calcallo or, far away, who are driving past other health services to get to Sunshine. Sunshine is becoming quite overloaded, and so what will be happening as of next week is that those patients who are coming from outside our catchment are going to be redirected to health services closer to their home. And if a GP refers one of those patients in, the GP and the patient will be notified that the referral has been forwarded on to another health service. So you may start to see some of that happening. So it's helpful for the GPs to know, so that if a patient, from those areas sort of says, I want to come to Sunshine, just to be warning the patient that the referral won't be accepted and will be redirected elsewhere. The other thing that is happening is that we are starting a centralised referral service for antenatal referrals into the combined Western Health Services. So there's a referral hub will be at Joan Kerner, and those referrals will be triaged based on where the patient lives and if they need any specialised pregnancy care. So if you've got a patient who's at low risk and lives up sort of in the Bacchus Marsh corridor, they're likely to be referred for their pregnancy care at Bacchus Marsh. Whereas if they're a Bacchus Marsh patient and got lots of risk factors, their care will occur at Sunshine. So just so you're aware of that and prepare patients for those changes, which may be a bit challenging for some of them. So there's the fax number. So it's the same as the current fax number into Joan Kerner for Women's and Children's. If you've got any queries, we're happy to have them directed to us at the GP Integration Unit, or you can contact the Women's Clinic on that phone number there. So, so again, many thanks to everybody for attending and giving up their time this evening. Thanks to Thomas for great presentation and updating us all on fracture management and the services available. Thanks to Steph behind the scenes and David for attending, and we'll let everybody get on with their evening. Thank you very much.
Thanks, Jo.
Thank you, Jo. Good night.